Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. If you find this episode helpful, if you find this podcast helpful in general, please do me a huge favor, leave a rating review on iTunes or wherever you're listening, and of course share us with friends, colleagues, classmates, and so on and so forth. So, help us grow this podcast, help more people learn pharmacology. All right, the drug of the day today is Nifedipine. Brand name is Procardia. Adalat is also another brand name. And I guess I'll stick on this topic while we're talking about two different brand names here. Those formulations are different. So Procardia XL versus Adalat CC. So they use different, basically, drug delivery systems. I'm not going to go into the weeds, but they are not considered interchangeable. So if you're a pharmacy technician, a pharmacist dispensing, those different formulations are not considered interchangeable. So what is this medication used for? It can be utilized for hypertension as well as various types of angina. Rarely it can be used for Raynaud's disease or disorder. And lastly, I'll mention it can be used topically. So in a compounded product, it can be applied topically for anal fissures. Not something I'm going to go into great detail here on this podcast. I'm going to focus more so on the oral systemic use of nifedipine. All right, so drug class. So nifedipine is a calcium channel blocker. More specifically, nifedipine is a dihydropyridine calcium channel blocker. Okay, so this selectively blocks the influx of calcium ions into cardiac cells, cardiac muscle, vascular smooth muscle, and ultimately this influx causes contraction of the vessels and raises blood pressure. So with the dihydropyridine calcium channel blocker and nifedipine, we block that influx and block that contraction of those vessels, if you will, and can cause some vasodilation and lower blood pressure. Now, I do want to take the time to remind you about dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. So, dihydropyridine calcium channel blockers, like nifedipine here, they tend to work more so just on the vasculature. Okay, so just on those blood vessels, and that's how they have their blood pressure lowering effect. The non-dihydropyridine calcium channel blockers also have action on cardiac muscle. So those medications like diltiazem and verapamil can slow the heart rate down, and you may see them used in situations like atrial fibrillation, versus nifedipine you'll never see used for atrial fibrillation because it doesn't have that significant action on the heart. All right, dosing, talk a little bit about that. So there's a couple different dosage forms. There's immediate release and extended release. I can't tell you the last time I've seen the immediate release used for nifedipine, and I'll get into that in a second here. The extended release is what you see more often. 30 to 90 milligrams daily is the usual dose range there. With that immediate release formulation specifically, it's not recommended to use these. Studies have been shown that it's not that great and causes issues as far as increase in significant hypotension and other adverse effects. So nifedipine, immediate release, short-acting, generally not used in practice very, very often at all. It's been a long, long time since I've seen it in practice. All right, so let's also remember that nifedipine is considered one of the medications to utilize in pregnancy when we need to manage hypertension. So again, I'm talking about extended release here, not immediate release. So that's a good nugget to remember. Definitely something that shows up on board exams for sure. Nifedipine has decent evidence to show that it's relatively safe in that patient population. Most of the cautions or precautions surrounding nifedipine involve the immediate release formulation, so not recommended to use nifedipine immediate release in chronic hypertension management, for example. Also, it shows up on the Beers criteria or the Beers list in potentially inappropriate medications in geriatric patients. And again, that's due to that significant risk of hypotension and possibly some increased risk of some cardiovascular events there as well. All right, let's talk adverse effects a little bit. So when we cause some vasodilation of the blood vessels, sometimes the heart can kind of try to counteract that and raise blood pressure. So there is the possibility for some reflex tachycardia where the heart rate maybe goes up a little bit. But I would say that the primarily, most common tested adverse drug reactions with nifedipine, I would say one, peripheral edema. So kind of that swelling around the ankles, that type of thing. That's definitely a notorious adverse effect of all calcium channel blockers. You may see a little flushing, some redness in the face. Some patients may report that. Hypotension, I think that makes sense. We're trying to drop blood pressure. We can't drop it too far. Other maybe less common things, gingival hyperplasia has been reported, so it's kind of a unique one there anyway. But overall, generally pretty well tolerated as long as we don't, drop that blood pressure too far, and the patient isn't having any trouble with, edema, flushing, and maybe some headache can be reported as well. I have seen that in practice. So those monitoring parameters, blood pressure, that's going to be your primary target there when using this medication. And then from a physical symptom standpoint, I would definitely look out for edema and swelling around the ankles and things. All right, let's take a quick break from our sponsor, and I'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, BCGP, BCMTMS, or the NAPLEX exam, go check out meded101.com/store. We've got tons of resources, help thousands of candidates pass their exams. So we can definitely help you too. So go check that out, meded101.com/store. All purchases there go directly to support this podcast. In addition to those pharmacist board certification resources, we've got other resources for nurses, pharmacy technicians, med students, so on and so forth. So go check those out. Lots of different things to learn, help you grow your knowledge and understanding of pharmacology, and all those resources you can find at meded101.com/store. All right, wrapping up with drug interactions. So the first two things I kind of think about are, what are we trying to do with this medication? So medications that can have additive BP or blood pressure lowering effects, alpha blockers, PDE5 inhibitors, other antihypertensives. If we drop that blood pressure too far, we could increase the risk for dizziness, falls, things of that nature. Usually not as big a deal in, younger patient populations, but as patients get older, this can certainly be a growing issue over time. So there's that side of it, the kind of additive blood pressure lowering effects for drug interactions. And then we've got the flip side where we're opposing the blood pressure lowering effects. So, medications like stimulants, for example, used in ADHD, they can raise blood pressure, or narcolepsy, or things of that nature. So that's definitely, one classification of medications that I pay attention to as far as raising blood pressure. Another one, NSAIDs, commonly used over the counter. Particularly, this is generally a dose-dependent effect. So, higher the NSAIDs dosing that you use, the more often you take them, that sort of thing, probably the more likely you're going to see some of that opposition to blood pressure lowering medications. So, always keep that in mind whenever you see patients with, blood pressures that are higher. Take a look at that medication list. Make sure that we're ruling out medications as a potential cause of hypertension. All right, and then we do have some CYP3A4 interactions with nifedipine, so a little bit of a downside here. CYP3A4 inducers can reduce concentrations. CYP3A4 inhibitors can raise concentrations. And give a little plug to my food-drug interaction book here. There's definitely a food interaction you should pay attention to with nifedipine, and that is grapefruit juice. So if you recall, grapefruit juice is a CYP3A4 inhibitor. So that's going to ultimately increase concentrations of nifedipine, which could lead you down the path of having an increased risk for side effects. So edema, could drop blood pressure too far, for example. So definitely something to pay attention to there. In addition to that book on Amazon, I've got it on food-drug interactions. I do have an additional podcast specifically on grapefruit juice and some of the common interactions that happen with this food. You can find that at Real Life Pharmacology. Just hit the podcast tab and then search grapefruit juice, and you should be able to find it, no problem. So, good little bonus episode to take a listen to get some of those drug interactions on grapefruit juice. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, leave a rating and review on iTunes or whatever your platform you're listening on. I greatly appreciate that. Share us with your friends, colleagues, students, anybody who needs some pharmacology education. Greatly appreciate that as well. If you got comments, suggestions on upcoming episodes, things you'd like to hear about, definitely reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care and have a great rest of your day.